Friday night, so I look forward to mingling with some of you there. So it's really my great honor to introduce our kickoff keynote session for today. So let's get to the right slide first. So we're going to have the Diagnostic Management Team, a solution for diagnostic error in inappropriate test utilization. And so following the session today, you will need to complete the online session evaluation. Once the evaluation is completed, your CE organizer code will appear on the screen. And links to your online session evaluations can be found on the handout that you received at registration today. There are also links located in the ASCLS meeting app, which is available for download from the iTunes or Google Play Store. So today's speaker is Dr. Michael Laposata. Dr. Laposata is the professor and current chairman of the Department of Pathology at the University of Texas Medical Branch at Galveston. His clinical focus is in blood coagulation, and he is a renowned speaker, author, and researcher. So please welcome me in joining Dr. Laposata.
And thank you. I'm delighted to be here. I know so many of you. I've worked with a number of you over the years, and I'm greatly honored to give you this message. I think that you probably know my story of being a resident in straight laboratory medicine at Washington University and walking in the first day and wondering, what do I do? Because it was pretty clear that everybody working at the bench had a job, and everybody needed the lab test results. So what about me? I was going to be the director of the lab. What was the role? And it occurred to me in the first year as I got pages over my beeper, people didn't know which lab test to pick, and they could not interpret any of it. And it was getting worse by the second. We just kept adding coagulation tests, and they were more expensive, so people spent more money for no reason. And they didn't know how to use the right test, so people would stay in the hospital an extra week waiting for a diagnosis. So everybody's trying to do better, making great lab tests, and the big problem is nobody knows how to use this laboratory anyhow. So somehow that had to be fixed, and I realized that was the mission. So in 1984, when I did this at Washington University and said, we have to fix this problem, I then got my first job at the University of Pennsylvania in 1988, and I wanted to interpret the coagulation tests, patient-specific, expert-driven, timely interpretations. And the chief of hematology said, you can't do that. He said that when you do that, you get the diagnosis too soon. So therefore, my fellows don't get any of the professional revenue, and I can't pay them. And that is too big an impact. And I said, isn't the patient first? And he said, second, after my fellows. And he was the full professor, and I was a newbie, and I knew that was the end of that. So then I moved from Penn, and I became the director of the clinical labs at the Mass General, the first one. And I said, we're going to do this. And we did it for coagulation. I did it with Betsy Van Cott, who's still there. We shared 6 months apiece every day, doing about 30 of these interpretations. And we had a huge impact. But we couldn't get it to spread to the other sections of the lab, and that's me even being the boss of the division. So then I went to Vanderbilt as pathologist in chief, one notch up, and I was able to put together, with everybody's help, about 6 of these so that we could do transfusion medicine and microbiology. We ended an epidemic with contaminated prednisone syringes, the Diagnostic Management Team at Vanderbilt. It was pretty clear it was a good idea, and so the University of Texas asked me to come. I've been there 3.5 years. We're trying to do this through the whole system, the whole University of Texas system, because through the 6 or 7 big medical centers, we have experts on everything. So while you're doing everything that you are doing, there is a huge change to create what is now called the Diagnostic Management Team. You realize that it took until the late 1940s to put surgical pathology together. Nobody did biopsies. If they did, it was a rare event. So in the 1940s, people said, you know what, we ought to cut sections, stain them, and give them to somebody to look at them to decide if it's benign or malignant. And it was absurd to go back to a surgeon and say, here it is, you figure out if it's cancer. And the radiologist got it in the 1980s. When the CAT scan came, they didn't just hand back the film. They said, we're going to interpret every one of these, and we're going to bill for it, and we are going to be indispensable. What do we do in the labs? We just keep generating more data. Cystic fibrosis, 2,000 mutations. Good luck. Delta F508, G551D. Should I use Kalydeco? It's $275,000 a year. Which mutation do you have? Holy cow. All this expensive stuff has clinical implications. We have to interpret the lab tests. We can no longer say positive, negative, or 13.3. We had our first Diagnostic Management Team meeting in Galveston last year, 2017. We had a big crowd. People are interested in trying to figure out how to make this happen. We had our second one this year. And the other big driver in the last several years is that in 2015, the National Academy of Medicine, maybe the most august body in the United States, created a panel, a 21-member panel. I got to be on it. And it was to focus on the problem of diagnostic errors. It turns out there's tens of thousands of people that die in America every day because they told you had asthma and you had a blood clot in your lung. And every time you go to the doctor, you run about a 1 in 5 or 6 chance of getting the completely wrong diagnosis. So how do we fix this? And it turns out that the Diagnostic Management Team, after I told everybody how it worked, was one of the few solutions offered in the report that came out in 2015. So you all have to know about it. Not only that, you all have to participate in it because we don't have enough people in this business who can actually interpret the lab tests. If you've been working in a coagulation laboratory for 10 or 15 years and somebody says the PTT is prolonged, you're going to know factors 8, 9, 11, and 12, lupus anticoagulant, and heparin. Boom, 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 boom. Guess what? None of the doctors in your hospital know that. None. So if that's where the world is, then how come you, if you know all that, aren't sitting in a team that meets every single day that fixes that problem? And in fact, at UTMB, we now have classes, 3 of them now, for the doctorate in clinical laboratory sciences. And that means that you can take your bachelor's degree in CLS or MT and turn it into a doctoral degree in 3 years. Only coming for the summer times, and what do? Or the 3 or 4 months, whenever it is, 3 or 4 months, 3 times to do DMTs. So you get to hear all the cases. There's a course of filling in the blanks of your knowledge. What's echocardiography for? Well, it's to look at the valves of the heart. Okay. What is a STEMI? ST elevation, myocardial infarction. We fill in the blanks of the clinical knowledge. And the bottom line is that the people who are most suited to lead these DMTs are probably you. Because the pathologists are not doing it, as you'll see in a minute. The Ph.D. laboratory directors aren't doing it. And when this first class of 7 graduates with a doctorate in clinical laboratory sciences, I hope to hire at least 2 or 3 of them. Somebody will emerge who's been in the laboratory all these years to be the laboratory director, and they're going to do DMTs. So let me tell you what they are now that I've set up the whole rationale for it. And so here's the title. We're going to talk about 3 things the DMT does. One is it helps you get the right diagnosis. It also helps you pick the right tests, the ones that you ordered too often or you didn't order at all, so the patient took a long time to get a diagnosis. And the 4th thing, which is really kind of amazing, is that we are now doing autopsies through the DMT. It's incisionless. There is no body, but we are going after every diagnostic decision that was made about a patient, and we're fixing all the ones and say, that was wrong, that didn't work, you got that half right, and we're improving our performance because we have a bunch of experts who are looking at all the diagnostic decisions. So, this is the basics about a diagnostic management team to make sure everybody knows. So what we have done since laboratory tests were initially performed is that we throw the tests over the wall. So here you go. That's the diagnostic doctors and all of us in laboratory medicine sitting there, not frowning, notice. Not frowning, we're just doing our job. We're throwing over the pieces to somebody who has no clue what a heterozygous prothrombin 2021O mutation is. Even though it happens in 1 out of 40 Caucasians, good luck, figure out how to anticoagulate. That's why it's on the ground. So they don't know what to do with it. You might get warfarin for your entire life and you probably don't need it at all because you have that mutation. Those are the kind of mistakes that are rampant across the United States of America. And we're watching it all happen. It's like giving back the CAT scans and the MRIs, just everything back to the doctor and say, you ordered it, here it is. You figure out what all the shadows are. This is totally intolerable at this point. So what we have to do, and I put there diagnostic doctors, knowing it's a team, we have to put the puzzle pieces together. There should be no wall. So it should look like this. Here's your diagnosis. You have a pulmonary embolism. You have a hypercoagulable state to explain it. Your IgG anticardiolipin is markedly elevated, and there's a heterozygous factor V Leiden. The suggestions are, bop, 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 and there they go in the recommendations. That's where we got to get to. Sounds preposterous. How could we do that? It is a challenge, isn't it? Because we have to have enough members of the team. We have to make it possible for a 100-bed hospital somewhere who might have one pathologist and maybe a Ph.D. lab director and a team of people working at the bench to be able to get the same kind of care. We cannot have a disparity of care. So there are ways to solve these problems. So we are past the positive and negative and the number. So let me just show you, this is an example of a medical record report. This was at the Vanderbilt stage. Remember in Boston, we had just coagulation. And on June 30th, 2010, the day before we started producing these narrative interpretations, that is what was in the report for a patient. So I went to my friend, the chief medical officer, a very distinguished physician who had been at Vanderbilt 27 years. And I said, Alan, what can you tell me from this report? He said, not much. He said, I start with the asterisks. So there are two. And you'll see that one of them is 43.6 on the second line. He said, I assume that's the PTT, but I have no idea why there's a PT after it. I said, that's actually an abbreviation for patient. Bad idea, isn't it? Yeah. And then he said, I have RVVT, and for that I'm going to have to go to Dr. Google. I have no idea. So what about all the others that are normal? I said, they're all important negatives. He said, I have no idea what they mean. He said, and I don't know why you abbreviate them like that. And I explained to him that the people in IT told me I only had 6 characters to abbreviate something. How do you abbreviate the PTT mixing study on immediate mix at 0 hours? Well, it came out P plus NOHR. Nobody knows. When we had to abbreviate the test for the antibody that produces heparin-induced thrombocytopenia, HEP appeared. And you know what everybody thought that test result was for? Hepatitis, not heparin allergy. So you kept getting your heparin and then you thrombosed the femoral artery and you lost your leg because people didn't know what HEP stood for. And do you think that that was what showed up? Did people go back and say, I'll tell you why there was a diagnostic error? People didn't get enough knowledge to know that HEP in this case was heparin. So here's what happened the next day. That very case, I took the data and I said, look, you don't have to order the test anymore. You just check a box that says prolonged PTT evaluation. We'll pick all the tests. We'll do all the tests till they get done. We'll do the necessary ones. We'll skip all the ones that aren't important. And we said the PTT was elevated and the PT was not. They did a thrombin time at Vanderbilt as a screening test, unnecessary. We changed that. And then, since it was prolonged, we picked the next test, which is a PTT mixing study, and it failed to correct. So what is the most common thing for a PTT that fails to correct? It's a lupus anticoagulant. So we did that test. It's called the Russell Viper venom, and guess what? It was positive. And that's the explanation for your PTT. And by the way, it's a prolonged PTT, and even if you're doing neurosurgery, you don't try to normalize that thing with fresh frozen plasma. So I had an ENT friend who said, I read your reports when you were doing this in Boston in 1995. After the numbers, there was a paragraph underneath it that said, your patient has a prolonged PTT because it's a factor 12 deficiency, and patients with factor 12 deficiency do not bleed. He said, I was giving all those kids fresh frozen plasma for my whole career. And I said, Ron, were you giving them plasma between 1981 and 84? And he said, absolutely. And I said, 1 out of every 20 bags had HIV. Those little 8-year-olds that came in whose tonsils you took out, they were dead 3 years later. And the ones who got hepatitis C virus, they're getting the $1 million liver transplant 15 years later. So do you think everybody knows the root cause? The root cause of what? We teach lab medicine for a few hours in 4 years of medical school. We ship people out. We give them a mouse and say, pick among 10,000 tests. Good luck. We're not going to give you any help. It's like a quiz game, right? And then you pick all the wrong tests and somebody dies. So that's really what's been happening. It took till 2015 and the National Academy of Medicine to report to make it clear that we're in the center of the bullseye. You know, all this stuff about how valuable are you? We are the most valuable. No diagnosis, no correct treatment, no getting better. So we are the first step in this process. So in any case, that made a big difference. We realized that a lot of people said they were doing Diagnostic Management Team activities. I've been talking about this since we started it in the mid-1990s. So when people tell me they're doing a DMT, I ask them several questions. One is, how often does the team meet? Some people have said, we meet once a month to look at the coagulation deaths. I said, don't you think that people need the answers faster than once a month? We actually have a child abuse DMT. There are kids who have bruises and bleeding, who have underlying bleeding disorders, and the caretakers are taken to task, to court. There's probably 600 in prison today, because the court doesn't understand, nor do the pediatricians understand, that the kid has von Willebrand's disease. They bruise easily. So the one father tossed his kid up in the air, and there were some bruises where he caught the kid, and he was separated from his family for 2 years, and they took Sam away. So that we can do once a month. We work with attorneys, we testify, it's all pro bono. And this kind of thing, you have to ask, how often do you need to meet to give somebody an answer that will change the treatment? So that's the second point. The report must be delivered before or during the time when treatment decisions are made. The third thing is, you can't just say positive. Everybody says, well, I'm doing serum protein electrophoresis. I look at the bands. Well, what are you doing? Band seen in the beta region. What's that tell you? What you really need to know is it an IgA lambda and was it an IgG kappa before? Is this a new monoclonal protein? Is this multiple myeloma getting worse? If all you're doing is saying positive or I see a band, you are of no help. And then the fourth thing is you got to put it in the medical record. Many people in microbiology have taken me through the lab and said, look at my lab. We meet with the pediatricians at 10. We meet with the adult doctors at 11. Nothing goes in the chart. You just walk around and say, look at that culture. Look at that culture. You think one doctor is taking care of that patient? You don't think that patient's coming back and going to get another team of 10 new doctors? I would see patients, had a practice, put my interps in to the chart for my own patients. Did I know what it was? Yes. But I was not going to be the only person looking at that patient. That's why it has to go in the chart. So there are a lot of people who have case conferences. Thousands of departments have clinical service lines, and it's not a DMT if you're not doing all those things. So the true DMT is you put a line around a certain group of cases. Maybe it's everybody who has an abnormal thyroid. No, maybe that's too big. Maybe it's everybody who's pregnant and has an abnormal thyroid test. And you interpret those. Whatever it is you know, turn that into 3 sentences or 4 sentences that every doctor can understand. That's what we have to do. And that can be what we do. That is all the people in this room. It could be that this is a co-signed report that happens with somebody you work with. But the bottom line is, if you are the expert, your information has to help this person. And then you do all those cases surrounded by that line, and you put it in the chart. And so what else does a DMT accomplish? So what we've said right now so far is we are reducing diagnostic error. There's no doubt about it. As we evaluate everything, we reduce diagnostic error. And when we say it's a completely negative workup, in somebody who's been losing 3 or 4 pregnancies and had a clot, maybe that pushes you into another direction. So you do a different investigation and find out what really is wrong. Now, utilization is the other thing we control. Because when somebody wants to get a protein C and a protein S, and they're on warfarin, the resident who sees the case first, and the person at the bench, the clinical lab scientist, says, you know what? This patient's on warfarin and they want a protein C and S. Warfarin interferes with those assays. It'll bring the values down. If you have a low value, you don't know if it's because of the drug or they have a low value from birth. So you can't sort it out. We should not do those tests. Somebody has to say, don't do those. And you know what? Somebody also has to say, you missed the 5 tests you really need. So let's take a look at this problem. It's overutilization and underutilization. And can we help fix it? So let's ask these questions first. So which one's more costly? Doing too many tests or doing too few tests? And the other is, how can we figure out how much it costs? Right now, our hospital in Texas, the legislature decided that they should give us less money to run our hospitals. Boy, has that been a blow for all of you living in Texas, right? And so the committee said to our chancellor at the University of Texas, you should take this money out of your endowment. He says, we're caring for the citizens of Texas that are indigent. That shouldn't come out of the endowment. Bottom line is, we got to meet targets like $30 million that we didn't expect to meet last year. And so everybody's looking carefully at what we should do. And this particular thing could save money and improve care. How does that happen? So let's take a look at this. So how do we optimize lab test selection? So the goal, so we all know the goal is you take the clinical context. This is a patient who has back pain. They did an x-ray. They found lytic bone lesions. Now it sounds like it might be multiple myeloma or Waldenstrom's, right? So you have a context. Then you look at serum protein electrophoresis, urine protein electrophoresis, and you do all the right tests and no extra ones. Now, if you look at what everybody's talking about, what's the bigger problem, doing too many tests or too few? Most people say that it's doing too many. In fact, when Obama came forward and said, we have a problem with spending money in healthcare. We spend $2.2 trillion. The waste is estimated to be $800 billion. $800 billion. By the way, the budget of the National Institutes of Health is $30 billion. If Joe Biden wants to eliminate gliomas because it killed his son, it's not going to be from little things. If you fix $800 billion and you can save $80 billion of that, you will triple the NIH budget. There goes glioma. Because instead of approving 5 grants to study it, they'll have enough money to approve 50. And then you'll figure it out. So this huge amount of waste is often surrounded by what we do. So the question is, how do we step forward to make it better? Okay, now, the determination of over and underutilization is quite subjective. I'm not really thrilled about the reports where somebody on the front page says, hypercoagulation testing is not necessary. In my clinical practice, when people come in and they've had a clot, one of the first things they want to know is, why did I get my clot? That's a fair question, isn't it? Then I guess we better find out what risk factors you have for getting a clot. So we're going to do a hypercoag test. So people in another country, maybe, okay, well, we don't have enough money in whatever country, we can't. In America, we're going to try to figure out why you had it, because your kid might get it too. And you might be able to avoid the risk factor so you don't get a second one. So big difference, and a lot of people take this picture, which shows clearly there are errors on one end. You didn't do the right tests. There are errors on the other end where you did way too many tests. And there's a big gray zone in the middle. And some people can justify the use of those hypercoag tests, and other people will say, you know what, you didn't need them. And the reason that they can't sort it out is they want to make one general law. That doesn't work that way. You have to find out what this patient is. right? They got 10 kids and 3 of them have clots. You're telling me you aren't looking for the genetic risk factors for thrombosis? That's nuts. So here are some in COAG. Some people justifiably say, why should we do factor 12? Yes, it prolongs the PTT, but if you're low, it doesn't make you bleed. My argument would be then you keep getting admitted to the hospital, they see your prolonged PTT, and they keep doing a workup. So after you've had that done 6 times, why don't you finally figure it out? Some people say, well, there's 8 different lupus anticoagulant tests. How many should we do in our lab? How about 2? Are both anticardiolipin and anti-beta-2 glycoprotein 1 tests, since they're similar, redundant? A lot of people have factor 11 deficiency. Most of Jewish descent, some have argued that if you're not Jewish, you shouldn't have the test done. And there are many more. So that gray zone in the middle is big. Let me give you a little perspective about this as a doctor who sees the patients and uses the lab. The lab tests are cheap. You know, even the lab tests that cost $500 in the context of we could nail the diagnosis if we spend $500, that's really cheap. That's a day in the hospital or less. Day in the hospital in Boston, it was $2,000 a day. So if you can get them out of the hospital a day sooner and spend $500 for a test, do it. But it's got to be a useful test, not one of the tests that, oh, there's 5 of them in the panel and we'll put them in. And you got to watch out because there are a lot of people who make commercial assays. How about the hypercoag assay where they put factor 5 Leiden, prothrombin 20210, and then another thing called MTHFR. Well, 15 years ago, we realized that's not a risk factor for thrombosis. But the fact is, we could sell you the one with the 3 tests in it, and then you'll do it because it's the same sample, and you'll go bump, 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 right? Not a good idea. Okay, so it is difficult for non-experts to decide which tests you need. So who should decide? Well, I would argue we should decide. If you're going to do a PT or PTT, fibrinogen D-dimer, anybody can do that. If you're going to go beyond that, please don't hunt and peck. Please just get to a diagnostic management team that can tell you here's what to do. Or you could set up all your COAG testing like we did, and now we have 9 different things you could order for COAG. We're still trying to get people to use them. It says prolonged PTT workup. People don't have to know which factors are missing anymore. We can't expect doctors to know all of this. It's just too big. Now, when I first got to UTMB, we did a study where we just took 200 cases and said, how many of these have an over or underutilization problem? A mere 77.5%. So 3/4 of the time, the wrong tests were ordered or not ordered. Guess what? It was the same number when we did the study at the Mass General Hospital. So just in case you're wondering about all those doctors who went to Harvard, who got a bazillion on their medical college admission test, right? Same number. So here's the big problem. If you look at the bottom, underutilization, it's 3 times bigger than overutilization. There have been 3 studies. We did one, it's the Sarkar reference, and it's clear that people are doing too many CBCs on you. You're coming in, you have a normal hematocrit, normal white count, normal platelet count, and somebody says CBC every day. What the heck for, right? By the same token, the very test you really need to find out why you're an infertile male, and maybe it's a cystic fibrosis test, right? And now we got to start looking at mutation. That never gets done. I'm sorry, you're infertile. I can't figure out why you don't have any sperm. It's because you didn't do the right test, man. Overutilization is spoken about more, but it is less of a problem. Let's look at it. Remember now, only 55% of patients in America for common disorders get the right evaluation. That means we undertest that many people. So the cost of overutilization. We can count this up pretty well. We say, well, you did too many complete blood counts. If you have a hospital with about 500 beds, you include the budget so that it has the blood bank in it. Maybe it's $25 million. And let's say a CBC is $10 a test and 25,000 are unnecessary. You do that math, 250,000. How much did you really save on the budget? It's about 1%. So there's a lot of data showing we don't need to do these routine tests so much. But if we're going to fix overutilization, people are going to say, nice job, right? But you can't do anything. You can't really hire any people from what you saved. Now, what about the send-out test? People are looking at that as an overutilization target. Now, if you have a genetic test that costs $5,000, like a whole exome analysis, and you do 500 of those, you don't need a year, and you do that math, that's $2.5 million wasted, put through just a money shredder, no use at all, and that's 10%. So people have targeted the send-out lab budget because it's a bigger money target for overutilization than the routine test. The trouble is there's a lot more data for the routine tests to say that they're unnecessary. When I tried to bring up some of the testing issues to our neurology group in Boston, I said, do you really need to do the genetic testing for ataxia? Not balanced, right? So you're wobbly, right? And the genetic tests for ataxia were costing us about, I don't know, probably $1,000 a test. So I brought them in the room and they said, yes, we do. And they said there are 18 types of genetic ataxia, and with this test we can rule out 3. I said, so what about the other 15 then? How do you sort those out? They said, we don't. We spend all this money, $1,000, to rule out the 3. And they said, and that's why we're man's greatest hospital, MGH. And I thought, wow, what do you do with that? Really, that's kind of a hard argument. So the send-out testing is challenging because we all work in the lab, we're all kind of generalists, and when you go up against neurologists who read every single neurology journal that came out yesterday and before, it's pretty hard to make a cogent argument about, no, you don't need that. Now, here's another thing that's happening. You heard this term yet? Diagnostic odyssey. I have no idea why the kid is a floppy baby. No idea. So people at Cornell in New York City said, you know what? These little babies, floppy babies, many of them are going to die. We have about 3 days to figure out what it is. Somebody says, let's do a whole exome analysis and look at 23,500 genes. And everybody looked at that person and said, you're nuts. And so guess what? They did. And what they were surprised to find out, because they couldn't interpret all 23,000, is that they looked for about 200 or 300 common pediatric neonatal disorders. And they made a diagnosis in about 40% of the kids, and they saved half of them. Okay, is your baby's life worth $5,000? Are you kidding? Of course it is. So the diagnostic odyssey, which sounds crazy, overutilization, right? Now, it's the way to do it. So what happened 5 years ago? Who would have thought a total exome sequence for a floppy baby made any sense? Now it's standard of care. You work in a hospital, you got neonates in a NICU, right? Nobody's doing whole exome sequencing for those kids and getting the answer in a day. You got deaths in your hospital that are preventable. Not good. And it's fixable. Trouble is, of course, for all of this, none of us tell the patients. None of us say to the patients, by the way, we could have spent $5,000 for a whole exome analysis, and we'd have a 40% chance of finding out why your kid's a floppy baby and died, but we didn't want to spend that money. That's crazy, but that is what's happening. So what was once considered overutilization, whole exome sequencing, now becomes a problem of underutilization. It's 5,000 tests, but it saves an entire life. So underutilization, by definition, is a diagnostic error. Overutilization, we're wasting money. Underutilization is, you came into the hospital on Monday, we don't have your diagnosis and it's Thursday. So the diagnosis is delayed. Okay, diagnostic error on that account. Or we never figured it out. You just kind of got better, so you went home. And they say, I don't know what it was. I went to the hospital for 3 days. I kind of felt better, and that's it. Now I'm back. So that is a diagnostic error, delayed or a misdiagnosis. So, of course, everybody wants to know, how much does this cost? Underutilization. And this is the big problem. Now, this is not said with any judgmentalism. It's just a fact. 95% of the hospitals in the United States of America are led by people who do not have a medical background. That's a fact. So therefore, it's a little hard to understand some of the things that appear to be necessary but expensive. And the other part, of course, is that we're all held to our own budget. So let's look at this. So I'm going to give you an example. I came home from Paris. My wife and I went to Europe 2 years ago for the summer. When I got home, I put on a pair of shorts, and Susan said to me, "Your left leg is bigger than your right leg." And I said, "Oh my God." Well, I could have had a Baker's cyst, sort of a low incidence thing, or I could have had a deep vein thrombosis after a 10-hour flight where I didn't get up much. And so what's the consequence of missing this? I went to an ED. The ED doctor said, "It's not that much bigger." I said, "It's bigger though, isn't it?" "Yeah, it's bigger." I said, "You want to do a test for it?" This is a little bit of a quiz. "I don't think so." I said, "Well, what about a D-dimer test?" She said, "I only do a D-dimer test for clots in the lung." I said, "What about clots in the leg?" "Nah." I said, "Let's do a D-dimer test." So she would have saved some money, D-dimer test, if I hadn't talked to her for so doggone long, 15 minutes. Then she could have seen another patient. So there's more money there. So you're reading the right part of the slide. And she didn't want to do a compression ultrasound to look for a clot in my leg. And I said, "I think you need to do a compression ultrasound. And not only that, would you turn the screen to me, because I'm going to read it." So that's what happened. I went in. Thank God it was a Baker's cyst. She could have saved a few bucks. She could have saved somewhere between $375 to $800 because I wouldn't have had the compression ultrasound, the D-dimer. But what could have happened to me if it really was a clot? Okay, this is pretty common, 20 years of age and older, especially for a DVT. There's a clot, see it in the right leg above the knee, if that happens to be where it is. Option one is it stays there and gets dissolved. It's a little painful, goes away, I guess I'm okay. Nothing happened. Basically, I got lucky. Second is a little piece of it, see that little chunk of red in the lung, the right lung? It could have been a small asymptomatic pulmonary embolism. She could have saved $875 by not paying attention to me, and my body could have taken care of it. Alternatively, the DVT could have gotten bigger, gotten into my inferior vena cava, then I got post-phlebitic syndrome. It's going to cost about $150,000 to take care of me for the next few years, because I'm going to be seen multiple times, because I'm going to have some tissue deposition of blood, and I'm going to have recurrent thrombosis, and it's probably going to cost maybe $50,000 a year after that. The other thing is it could have gone to my lung and made a bigger PE. Now I'm really impaired. I can't go to work. I sure as heck couldn't give this talk, because I can't get enough breath to put the words together. So that's also expensive. Here's worse. 1 out of 4 or 5 of you has what's called a patent foramen ovale. So every row, look around, one of you has a hole in your heart. And what that means is a clot can go from your foot, from your calf, and it can go through your heart and then get to the left side of the circulation, which means your arteries. And where does it go? When it usually goes, it goes to your brain. So 26-year-old woman I had once, oral contraceptives, factor V Leiden, she gets a DVT, boom, it goes through her PFO. She's a 26-year-old woman with a stroke, a residual stroke. So that's really expensive. You could have a small stroke or a big stroke. If you have a big stroke and it's totally disabling and you're 26, these are the people that are costing $200,000, $500,000 a year. And 7 and 8, you could die from a PE or a stroke. And by the way, it's free. So if you look at 3, 4, 5, and 6, and 6 is the big one, the disabling stroke, what does that cost? Now, I did one of these, and if you're a finance person, you'll be able to say, well, that's not close enough. Roughly speaking, if you put the numbers that I attached to that, they're reasonable, and said we're in a 500-bed hospital, which means there's a DVT that comes in, 1 in the emergency room, and 1 in-house patient after surgery every other day, that's what you get. So you're spending $15,100,000 to take care of this. And if you put an expert in to make a coagulation DMT that would stop all this misutilization and make sure that the underutilization stopped and people in the ED did what they were supposed to do, and it's not their fault because you only get a few hours in med school, how do we fix that? We put in a system to prevent it. Well, goodness, at $200,000 a year, that means we could hire 6 to 8 people. I could have an expert in coagulation, anemia, autoimmune disease, thyroid disorders, and everything else, just with this. So What we have to do really is to start paying attention to this underutilization problem. The death statistics are bad for your hospital. At UTMB, we had this incredible thing happen to us. There's the Vizient database, and we went from number 76 to number 9, and this year we're number 2. You know what we did? We fixed problems like mortality. How do you fix a problem with a lot of people dying in your hospital? It's this. You don't do the underutilization. You get a diagnosis, then you can treat. We got all these cases coming of people who did die. They're coming to the coag DMT if they have a heart attack, a thrombus, venous thrombus, or a stroke, and we tell them what we got to do better the next time. It has a huge impact. So reducing death has a big impact. Now, if anybody's an administrator in the hospital, please consider this. So notice the y-axis. It says dollars spent on length of stay for inpatients and supplies, personnel, and lab tests. So the first bar on the left, you went in on a Monday, you were short of breath, they didn't figure out what you had till Thursday, and it was a blood clot in your lung. You didn't get MRSA from the guy in the next bed, but you went home on Thursday, and you should have gone home on Tuesday or Wednesday. In fact, maybe you shouldn't have been admitted at all. So by being in the hospital 3 days, you're spending tens of thousands. That admission, that experience, tens of thousands. Okay, second bar. Now you were one of the unfortunate people who went in and you got a complication. Maybe it was an infection. Maybe you fell. Maybe something else happened where you got the wrong medicine. That's hundreds of thousands. You know what should really happen? What should really happen if you have a DVT that I thought I had is somebody hands you a pill of Xarelto or Eliquis, that is apixaban or rivaroxaban, and says, here, swallow this. And if it's not complicated, you are home watching TV in an hour. Now we can do it without penetrating the skin with a needle. You don't need Lovenox. So we have options, oral anticoagulants, and that costs hundreds of dollars. That's where the money is saved. Here's the problem. We can't generalize between institutions about those 8 different outcomes. What if you run a rehab hospital? You're going to have different things from running a general hospital. So the distribution of those possible 8 outcomes, different per hospital. So hard to generalize. And here is the other big thing. We are all held accountable for our own budget. So take a look at the one on the left. It says lab budget. If we correct underutilization, we're going to do more lab tests. And guess what? Somebody is going to be looking at me and say, Mike, your budget went up by 50%. So what did I save? I saved days off the length of stay. Whose budget is that? Not mine. In fact, it's all mixed in with the big general ledger. You know, this $4 billion at MGH, $3 billion at Vanderbilt. So when we save tens of millions, it's a small fraction, but it is a huge amount of money. But it's not on my budget. And people will argue that it wasn't you. When I was at Vanderbilt, we started coag rounds. We did this. We had somebody from the business school, Larry Van Horn, who took all the DRGs and said, what changed after we started coag rounds? On the y-axis is length of stay, LOS. On the x-axis is total charges. This is for pulmonary embolism, a diagnosis of a clot in the lung. The red dots are the dots for the people who were evaluated before coag rounds started. You'll notice the one in the far upper right. This person was in the hospital for 9 days and cost $85,000. $85,000. Look at the green dots. That was right after coag rounds had run for 5 months. It's even much better now that the doctors know. Notice that the green dots are coalescing into the lower left. We shaved an entire day off the length of stay. That's big money. And here is intracranial hemorrhage. The green dots coalescing into the lower left, the red dots scattered all over the place. But you know what? It wasn't our budget. I will give credit to the people at Vanderbilt. They said, we need to build more of these DMTs because you're really saving money. The president of the hospital came to me and said, you need a DMT for lower back pain. I said, that's kind of out of my wheelhouse, Dave. He said, well, look at what you're doing. You've got 3 experts in a room. They read the literature. They know what the current recommendations are. And you then make recommendations to people who are being evaluated. Who cares if it's a lab test or a radiologic study? If it is diagnostic, we want the most informed people telling others what to do. He said, we take care of back pain 12 different ways. We have people coming in and getting MRIs every month. We have other people who are getting nothing. We have other people who spend all their time at the chiropractor. There must be a set of recommendations. Set up a DMT for lower back pain. And he realized something else, and that is the world is not all about revenue. He got the fact that it's better to save $1 million than earn $100,000. So this is a set of obstacles to DMT creation. Why has there been no emphasis? I've been talking about this since 1995. What the heck is going on? It's the external environment. So let me just tell you, it's changed. When I was in Nashville, there were a lot of country music stars. Bonnie Raitt was a music star who was 52 when she had her big hit. And they said, wow, how does it feel to be a new sensation? She said, are you kidding? I've been singing in bars for 25 years. It took me 25 years to get a hit. So this has been cooking for a long time. The external environment changed. The doors opened. The National Academy of Medicine said, stop killing all the Americans. This didn't show up in the political election. We talked about Benghazi, not that that's something we shouldn't, but how many people, right? There's about 64,000 deaths from diagnostic errors in the United States, not one mention. Not one mention. Okay, number one, we don't have enough experts to lead the DMTs. This is a problem specific to the United States. There is an inordinate financial incentive to look at glass slides if you're a pathologist. And there are few true pathologists who are actually doing DMTs. And keep this in mind. The salary, according to CAP statistics for reading glass slides, brings you $300,000 to $400,000 a year, and you work 48 hours a week. Now, that sounds like, oh, they should be paying attention to everything, except look at this. Going to med school is expensive. When I was at Harvard, we graduated half the class with more than $200,000 of indebtedness. That's not for your house. If you marry one of your classmates, you could be pulling down $500,000 of debt, right? Find somebody else. Find somebody else. So I don't think we're going to get there with pathologists because we have to change the incentives, right? And I will say, there are some possibilities. We, as the University of Texas, I'm not the only coagulation person. There's a guy in Dallas who's really good, and he could sign out the cases when I'm not doing it. So if you could get a big healthcare network and pull out experts for 10 commonly needed DMTs, like coagulation and autoimmunity, etc., then you might be able to do it. But here's a proposed solution, and that is stop worrying about the MDs. Wow, kind of scary, huh? You would think that the pathologists would be scared of that, and there are a few. I gave a talk in Jackson Hole, and the person who heard the talk went back to her hospital in Idaho, and she mentioned the talk and said, I was inspired by it. He said, who gave that talk? And she told him it was me, and he said, that guy's taking money out of my pocket right and left, and I don't like him. Anytime you do this sort of thing and you put the patient first, that means somebody else who was first, some other thing that was first, moved to second. So it is a problem. So what about it? If it's not MD-DO, could it be non-MD? I'll say more in a minute. Another problem is that they decided, hospitals and insurance companies, that they would only pay a few bucks for this. If I look at dermatology, if I just look at slides for DermPath, I can make about $300 signing out a case that takes literally 15 seconds. So if you work an hour and a half a day, you can pay your whole salary. My wife still wants me to retrain in DermPath. So when you do this, you get 25 bucks. You can't make a living. You may have saved a patient who was bleeding to death in the emergency room. Sorry, $25. So the hospital people have to understand that when you're saving lives, you're getting people out of the hospital, you're not even admitting them, you're saving millions. They have to understand saving $1 million is better than earning $100,000. But for people to get that, they have to know medicine. Because when you say, I can save you $1 million, they're not going to give you credit for it. The president of Vanderbilt Hospital told me after we showed the data from Larry Van Horn, I said, look what we did, Larry, with coag rounds. He said, you couldn't have done that. He says, the lab is like one big box, right? Don't you have like 4 machines in there and you put a bunch of tubes in them? I'll quit it, Larry. He was a little tongue-in-cheek, but he said, I think it was because we bought a new CAT scanner. I said, you must be kidding. We brought an expert to everybody's bedside who was bleeding and clotting, and you think it's because you bought a new CAT scanner that you had that improvement? That's crazy. So there's a little bit of convincing, because a lot of variables change while you're fixing things, and if 6 months goes by, they're going to say, it wasn't you. Here's the other thing that has to change. We can't have just MD pathologists get paid. So I have plenty of colleagues who are Ph.D. Laboratory docs, chemistry, micro, and they're doing the same thing for a DMT. Allison Woodworth is now at University of Kentucky. She was at Vanderbilt. She set up a DMT for hyperaldosteronism. She knew a lot about plasma and renin. She said, that's my knowledge. That's what I'm going to do. So she did it. And I wanted to make a video of Allison doing her DMT, figuring out which test to order and what it meant, generating the interpretation, and me doing mine and saying, how come I get paid and she doesn't? Something is wrong here. So now we're getting down to, could it be you? Should it be you who gets paid? And right now I think we're looking at this target of maybe it's the DCLS. So the doctorate in clinical laboratory scientist, absolutely, you've got the course that fills in your blanks. You know what echocardiography is. We've had the discussion about all these different things. You've looked at a bunch of EKGs. Oh my goodness, the ST segment is off the baseline. I know what that is. That guy needs a stent. Okay, that's all part of the education, along with knowing how to use these lab tests and talking to all the doctors about what they need. So, proposed solution is you got to pay everybody. If a psychiatrist has a psychologist as a partner and both get paid and one's an MD and one's a PhD, why can't we do this in the clinical lab? So, in America, you will be sued. I went to Holland. They said, we don't really sue doctors here much. And that's because we realize doctors are human. In America, everything that goes wrong, and there are a lot of diagnostic errors, the expense and the frustration associated with all this is huge. So it's a fact of life. I think we're going to have to learn that in the U.S., this is just the stuff that happens, and you're going to have to get through it. Okay, now what about this? The lack of interest in a DMT role by the PhD leaders. How come? So I've had a lot of discussions about this, and I wrote this question. What is the future for laboratory directors, MD and non-MD, who do not lead a DMT? So you go in, and for years, if the blood came in and the numbers went out, you did your job. If you got inspected by the Joint Commission or the CAP and you passed, you did your job. But you didn't wake up every morning and say, I need to look at all the tox analyses. And the ones that are really big questions, is somebody really taking the opioid for their medication, or are they selling it on the street? Let me look at that thing and see if I see the opioid metabolites, or if there's just an opioid in there, and if it was probably just spiked in there. What is that? That's your first priority. And so people don't want to do it. So there was a recent report about clinical chemistry and how hard it is to get anybody to do a DMT, despite the fact that there's so much in there. What about all the endocrinology and toxicology, for example? So this is the title of the article, Pathology's Stepchild. Clinical chemistry isn't very alluring. And then it said participating in a DMT would change the whole thing. And so asking a lot of people, PhD laboratory directors, how come you don't do this? Here's what I got. I'm not comfortable making a final diagnosis. Maybe you haven't had the fill in the blanks course. I understand that. I don't want to be woken up. Pediatricians get paid little, and they're woken up all the time. My kid has a fever. I've woken up lots with 3 kids. Worry about the loss of a court case. What do you know? Did you go to medical school? 4th one, would limit my research program. A real excuse for some. Would not be compensated. Yes, that's true, but most of us who run labs are compensated because we run the lab. Now these, I think, were probably just excuses. Who would fill in when I'm out of town? I need to see a DMT. For goodness sakes, come to the DMT meeting. Come next year. Come to Galveston. It's in February, too, so if you live in a cold place, it's going to be 70, okay? As a generalist, I can't know everything, and my personality is suited to talk to me. I picked this so I wouldn't have to talk to people. So, can non-MD experts lead a DMT? Now, when I first started doing the coagulation interpretations, people thought that when I made the first one, I probably had seen hundreds, maybe thousands of cases. When I was a resident at WashU, I was doing coagulation as a specialty. I probably did case conference 10 times, 2 patients per session. So I went to my first job with a big number of 20 cases under my belt, ready to diagnose Glanzmann's thrombasthenia, which happens like 1 in a bazillion years, you know. So the fact is, you learn on the job. If you're worried that somebody else knows more than you, forget about it. You know way more than all the doctors about lab tests, which ones to pick and what they mean, if you've just been in the laboratory for some number of years. So expert level information, filling in the blanks, can be learned. We're really excited about our 7 DCLS students. Raj back there is one of them, leaning against the back wall. Problem 4. Now, what do you start for a DMT? When I went to Allison Woodworth at Vanderbilt, I said, how about a chemistry DMT? She said, what do you want me to do, Mike? All the abnormal tests in a chemistry lab? I said, okay, let's narrow it down. I said, could you do endocrine? She said, too big. Could you do thyroid? Too big. I said, well, what you do should involve at least 5 or 10 cases a week. She said, how about hyperaldosteronism? I said, okay. So you see, put a circle around what you know. Write interps for those. Those are all the people who otherwise could have had a bad outcome, but they didn't, because you woke up in the morning and you said, part of my job is making a patient-specific, expert-driven, by the way, you're the expert, expert-driven paragraph that says what it is. So the anatomic pathologists have said, we don't need them because we're looking at glass. And we're making enough money, so please don't ask us to do this. The problem is that there's really no incentive. So to tell people, hey, by the way, there's 79 relevant mutations for breast cancer now. 79 that say something about which chemotherapeutic agent, what your prognosis is, and what are you going to do? Just look at the glass slide and say, well, this looks like ductal breast carcinoma to me. It's bigger now. 10 years ago, it was just look at the picture. Now it's look at the picture and know the genetic changes. At Vanderbilt, I was sitting next to a dermatologist, not a pathologist, a dermatologist who took care of melanoma. And he and I were friends, and somebody showed a slide of skin. And he leaned over to me and he said, hey, Mike, I don't care about any of this. I make all my decisions based upon the genetic changes in the melanoma cells. He said, to me, that's just confirmatory. So if you don't really know the pathology as well as the genetics, it's going to be a problem. Acute myelocytic leukemia, 53 relevant mutations. What is that? There's 17 mutations that tell us if we're predisposed to pancreatic cancer. I want them. I want them. Then when I have belly pain, one of the things I'm going to ask for is an abdominal CT if I have a predisposition to pancreatic cancer. So you can see all this genetic things makes the anatomic world turn upside down. So using the latest technology, providing more than an image recognition is important. Now let me tell you about the autopsy. And the reason why this happened is it happened out of frustration and anger. Our laboratory administrator was married to a dear man. And we had our operations meeting. It ended at 2:30. She called Leland, and nobody picked up the phone. And when she went home at 5 o'clock, he was lying there dead on the couch. So I had a lot of questions about this and we wrote an editorial on this. So there it is. He died several days ago, and I said, what happened? They told him that he was going to need a coronary artery bypass, but he could probably wait a few months. Well, he couldn't, obviously. And so when he died, the medical examiner said, we knew he had coronary artery disease. He had a stent in his left coronary artery, anterior descending. So I knew what Leland had was a clot in his left anterior descending coronary artery. But so if you did an autopsy on Leland, you would pull out a clot. What's that going to tell you? Does that tell you anything about risk to the kids and his grandkids? Does that tell you why this whole thing happened in the first place? And his wife didn't want to get an autopsy either. People don't get autopsies. just because it doesn't sound like something you want to do. But I wanted to know more about his thrombose stent, especially because I know a lot about antiplatelet agents. And I know that 15% of people do not respond to Plavix. And if you have a stent, if you've watched the commercial, Plavix is supposed to keep your stent open. Well, if 15% of people don't respond to it and you don't do pharmacogenomics to see if you respond to Plavix, then you're the test tube. And the way you find out it didn't work is you died. And we have two drugs that can be used just like Plavix, prasugrel and ticagrelor, except Plavix is 37 cents and prasugrel is $5 and ticagrelor is $7. Getting an idea here that money is the driver for a lot of this stuff, right? And nobody's counting all the other things that cost money. So I wanted to know why he could wait a couple of months. I wanted to do his pharmacogenomics. Cytochrome P450, 2C19 alleles. 15% of people don't respond. And I wanted to get a biopsy. You don't have to do the whole autopsy. Just give me a piece of his liver. I want to do a whole exome sequence and see if anything's in there. And it wasn't the point of a traditional biopsy. I didn't just say, here, go, find the stent in the coronary artery. So they brought his case to coag rounds. The DMT looked at every single thing that happened to Leland. And so this, we realized, was the way to impact mortality. We came up with 5 or 6 things we're never going to do again. And guess what they've done since? If you have a stroke or an MI or a venous thrombosis like a pulmonary embolism and you die at UTMB, you're coming to DMT rounds. And those of us who sit around the table are going to find out all the things that didn't go right. So we wrote an editorial. Of course, all the people who are worried about the traditional autopsy, we're keeping that. But there's a lot to be learned from doing this too. A few concluding thoughts. Here's your DMT. You want to know the benefits? So we get the right answer. That's third bar, diagnostic errors from misinterpretation. We fix over and underutilization, not completely, but we make a big, big dent in it. And we start figuring out if all the diagnostic decisions were right along the way. So you tell me in conclusion here, right? You want to have a diagnosis without a DMT? I can guarantee you that virtually everybody in this audience is going to get a diagnosis. You're going to be sick. If it's anything beyond a simple thing, you're going to get evaluated by a non-expert. The person who is nearest to you, who might know the most about it, is going to be the one who recommends what happens to you. And so you have non-experts providing most of the care, faced with hundreds of tests unfamiliar to them. Remember the story about my own almost DVT, and no one to advise them. Or we could put all these DMTs together, and no matter where you are, we can have DMTs scattered around the country, and everybody just says, I got a lady here who's 52 years old. She has a DVT in her right leg, and I'm not sure what to do, and I have a few questions. D-dimer, yes or no? What are the hypercoag tests? Can I send you the results when I got them? And that's the way American healthcare needs to go. So we're all in the middle of the bullseye. Who thought that we were this important? No diagnosis, no accurate result, all the wrong treatments. So hopefully you're feeling very important by seeing all of this. I had fun. Thank you.
Thank you. I think we have time for a few questions if anybody would like to ask Dr. Laposata any questions today.
Sir? I'll do my best. Oh, okay. I can. I'll repeat it. Yes. Sure. So for those of you who didn't hear it, there's a project going on in New Mexico that sounds like a DMT. What the real hope here is that the DMT will become so ingrained into practice that we won't have to have a meeting every year in Galveston to tell people they need a DMT. That is a spin-off. And there's a company called Tricor in New Mexico. Some of you may know about this. The guy who leads it used to be at ARUP, and he went to Tricor, and he's the big boss there. And they created a project called the Santa Fe Project. And there's a lot of people who are influential and want to do the job of helping people pick tests and saying what they mean. So really, if you have a new idea, gosh, you can use our roadmap or think of a different roadmap. I think that what we all have to do is put the patient first. If you come up with a good way to do it, and it's kind of like this, but it's your own version of it, do it. Thank you. Yes? So this is a good question, and it relates, excuse me, to insurance reimbursement. So there are two parts here. One is getting paid for professional work. How do we get paid for doing the interpretation? And the other, of course, is how do we get paid for the technical part? You did a lab test, you're getting paid for it. The technical part does not seem to be a problem. Meaning, if I took somebody who had a blood clot and ordered a bunch of hypercoag tests, I'm not going to hear from the insurance company to say, why did you order a factor V line? If I ordered something completely bizarre, maybe I would. Maybe somebody would ask me. The real issue here is the professional payment. And it takes you out of the sphere in which you're in. You're generating money for your healthcare institutions in the lab. You do a lab test. You know what? We just started warfarin pharmacogenomics. The reagents cost $80. Do you know how much that somebody who doesn't know anything about medicine priced that test at? $2,400. $2,400. How did you get that markup? Everybody's going to take warfarin and nobody's going to know who's hypersensitive. So the fact is that they did it because they thought they could get that money on the technical side. So the money will come on the technical side, even if they get half of it. We'll give you a discount. It's $1,200. What a break. We'll take that. 50% discount. Right? So that's a problem. You get a fake price, and then you give a discount on the fake price, and you still make 10 times the amount. It's crazy, but that's the way hospitals run in America. What I think really has to happen is we have to get paid for the stuff we do professionally. All of you. All of you. So that's a different. I hope that's clear. Two parts. Anybody else? All right. Oh, wait, there's one more. Can I take that last one? We'll take one more, please. Sure, yeah, so the last time I counted, I think I've done it 400 times. So you can see how big a challenge it is, right? Because think about your own circumstance. You're going to go home and you're going to be working on Monday, right? Anything going to be different for you guys? Most of the time they say, that's too big a hill, I can't. But you've got to start having a discussion. The discussion I can see all of you having is figuring out, if you work in a 100-bed hospital with 2 pathologists, it's, can we interpret any of this? Why don't we just pick this one, the thing you know the most? And maybe instead of just sending positive or negative, there's going to be 3 sentences. How would you feel about that? Would you sign the form? Let's do this together. Let's make a partnership. It's a curve that goes like this, and at some point the inflection will take it off so it's standard of care. Same thing for radiology, as I mentioned, and even surgical pathology. We have to hit this point, and I dare say it's coming. It's within the next 5 years. It will be a standard of care. Americans are learning about it because it's in the Wall Street Journal. Hospitals are deadly. Doctors are uninformed about diagnostic tests. It's all over the place. Did you watch the TV show called The Resident? I watched the first 10 minutes of that thing. The guy comes in for an appendectomy. The surgeon nicks the artery. The blood squirts in his face. The guy dies from his appendectomy, and they're sorting out what they could say that would make them not culpable. Did he have a family history of cardiovascular disease? Yeah, I think his father had a high cholesterol. Then that's what we're going to call it. It's not our fault. Okay, this is American medicine. Whether we like it or not, maybe exaggerated a little bit for television, but that's what we have to fix. And I think It's just rising to the top. The patients are ultimately going to push us. All right, thank you again.